Okay, everyone, it's 1 o'clock. Let's get started with this part 2 of our 6-part series on the ACM assessment program. Today we're going to go over the toe touching assessment, one of my favorite assessments. In fact, I've been using it for a long time. Let me just make sure we're sharing, everybody. You can see I'm going to go back and forth from sharing to using my skeleton, but yeah, the toe touch assessment, one of the key fundamental patterns that we really need to establish. There's a lot of literature on this. I've got some great research to share with you on some parameters around the toe touching pattern and the effectiveness of understanding a lot to this pattern. In fact, this toe touching assessment, you probably could spend half a day going over every nuance of it. I want to give you a really clear overview of why we're using the toe touching pattern assessment and the significance of this movement pattern in assessing your clients. So one of the things I'll tell you, and it's probably one of the things that is the easiest to do in learning this pattern, it's doing it, and doing it with as many people as you can, everybody. Anyone I talk to, one of the fastest and most simplest assessments you can do is just have them put their feet together and touch their toes. And this is just, I was going through some files looking for some pictures, and I remember I take pictures of everyone. This is just a smidget of the amount of people that I've looked at this pattern, and I've done this for probably over the last 10-15 years of collecting pictures, just looking at this pattern of toe touching and getting a good understanding of the nuances between each person. And I'll share a lot of this with you. There's a lot of research that I'll also share with you guys on a lot of different ways to measure hamstring extensibility, because this is what most people look at the toe touching pattern as a hamstring flexibility or extensibility movement or test. But there's a lot of stuff that you're going to learn as we go through this, that the toe touching pattern is looking at much more than just how tight someone's hamstrings are, and it's not a very good indication of a hamstring tightness. Even though someone will experience tightness in their hamstrings they're bending over, there's a lot more to be led to that. So the traditional hamstring extensibility test is a straight leg test, and it's measuring basically hamstring extensibility, but also we actually use it as a neural tension indicator. If someone has sciatica, it's a good indication as to whether this is a muscle problem or a neural problem. Neural meaning nerve, and implications of the lumbar spinal nerve roots, as well as sciatica or anything along that the chain of the sciatic nerve into the tibial or peroneal nerves. So laying on your back, raising the leg up 90 degrees is acceptable. I'll show you a little bit more about this, and then we'll do the test. This is a hip flexion test. With a straight leg raise, we're really looking at the musculature involvement of the hamstring and neurological, the neural tension, the nerve that runs from the tip of the toe all the way to your lumbar spine. But when you bend the knee, we're taking that hamstring essentially out of the equation, and now we're really truly looking at hip joint flexibility or flexion in that hip joint. And this is why with a straight leg raise, the acceptable range is about 90 degrees, and the acceptable range for a knee bent hip flexion movement is 120 degrees. In FMS and some parameters around it, they'll look at basically an unloaded hip flexion position, unloaded meaning you're laying supine, and keeping, there's some nuances as to how to do this test, but basically just have someone lie down and raise their leg up as high as they can without the opposite leg in extension, the lower leg, moving. You want it locked straight, knee in extension, toe back, and as the opposite leg raises up, if there's any movement in that lower leg, that's where the test stops. But if someone can get their ankle malleolus basically to between anywhere from the knee down, that would be unacceptable hip range of motion. I mean, we don't know, is it neurological, is it hip flexion joint, or is it hamstring tightness or extensibility? Acceptable would be getting the malleolus to the yellow line or the kneecap, and full range would be the ideal range would be toward the mid hip and knee, between the hip joint and the knee joint. Mid range of the thigh would be the ideal range to get to. But there are some drawbacks to this test in what we're looking for, and I'll explain a little bit more. The other test that was pretty much widely used and probably most accepted for hamstring extensibility is the sit and reach test, and this is pretty much what you'll see in just about any exercise physiology lab testing hamstring flexibility. Again, there are some other components that we're looking at, possibly neural tension. This also is a semi-loaded test, because now you're actually using activation of hip flexors, any kind of lumbar flexion to get into the sit and reach. You can look at this lady's sit and reach test just as an example. She would be scored. You can see that an excellent score is greater than 30 centimeters. That means past the line of the toes. She's probably in that excellent range, or highly excellent range. You can just see how far she's pushing. But from what we look at from a functional standpoint, where is the movement happening? If we were to actually measure her sacral angle relative to her femur, we'll look at that in a second, and then look at how much lumbar flexion she's getting to achieve this. What is it really telling us? It tells us that she has the ability to bend, but where is she bending from? And I think most of you guys will understand this. So there are some limitations to this test, and there's some great research on taking. There was the next step from this, obviously, is the standing toe touch, which has other implications that we'll look at. But there's some research I'll share with you on the differences between the sit and reach and the standing toe test, and the standing toe touch, and the correlations to, and they always go back to hamstring extensibility. So just be diligent and be critical about research when you're reading about the toe touch, the sit and reach, the straight leg raise. You have to really understand what we're looking for in in that research, to get an idea of how valid that research is. And so if most of the research will compare like a straight leg raise goniometer test, where we're measuring the hip joint versus the functional movement of that leg raise. And so just keep that in mind, because I found some research that really shows a poor correlation with hamstring flexibility and injury prevention. But there are so many other parameters that are involved in injuries. And so this was a study regarding hamstring injuries in Australian football players that had a very low correlation prediction for injury prevention. The athletes that had poor hip or poor hamstring extensibility actually were no better off than the athletes that had extreme hamstring extensibility. They're all that were extremely in the high or excellent range for sit and reach test, still were getting injured. So there are other parameters around this, and that's what I really want to share with you as we go through this, to understand how to look at that research and really take it for what it says. So then we move to the standing, this should be standing toe touch. Sorry about that. Toe touch. The standing toe touch is the test that we're using, and it's a pretty widely used now assessment. And essentially, to have somebody do a straight leg raise test, a goniometer test, there's apparatuses involved, and it's very hard to screen a large population. There are some strong correlations to what we're looking for in a basic toe touch and those more specific tests. But we gain a lot of insight and knowledge to the standing toe touch, and which is why I use it extensively. And it pretty much, I'll be honest, from this test, I can pretty much tell you almost everything I need to know about someone's functional abilities or capabilities. The only thing that I really strongly go after his toe touch is the ankle mobility, just to ensure that we have that. But the standing toe touch, we're looking at hamstring extensibility. Obviously, when people bend over, they always feel the tight hamstrings. Most of them will. We're looking at glute and the gluteal complex extensibility, the ability of the gluteal muscles to allow the hip to move. The toe touch pattern, if we really look at the, in fact, I'll add this in here so you can understand what I mean by this, but the center of gravity on just about everybody is center of their belly button. I'm sorry, just slightly lower than their belly button. And as our body moves through space, that center of mass has to stay balanced over 2 little feet. And so what we're really looking at in any of these movement patterns, whoops, I should have done this earlier, huh? But I thought I could share it with you. What we're really looking at is where that center of mass falls relative to a person's position that they're in. Let me just get this done. So what we're really looking to see is, as this person bends forward, where does their center of mass shift? If it shifts back behind their ankles where their balance is, this just shows a really good hip hinge pattern, and the center of gravity is finding its place on that stable base. The further, if you can imagine, the further this center of mass falls forward or less hip hinge there is, the more tightness in the posterior chain there's going to be. So it's really what I look at initially in a toe touch pattern. Where does their center of mass end in their position that they're falling into? And that will tell us a lot about how they stabilize and balance their body on 2 little feet, okay? So we're looking at center of gravity distribution, the hip hinge, limited hip flexion range of motion. Again, that's what the straight leg knee bent assessment tells us, is does someone actually have adequate hip range of motion in the socket, not necessarily the hamstring flexibility, but just their ability to flex at the socket joint. And we'll look at that in a second too. The lumbo-pelvic rhythm, we're basically looking at how well the pelvis moves relative to the spine and spine relative to the pelvis. I've got some research to share with you about that, and how that lumbar pelvic rhythm is really a strong indicator of potential risk for back injuries and nerve involvement and stuff like that. So that's a very important thing. We're going to look at this stuff as I show you some pictures. And then spinal compensations, we're just looking at how the spine reacts to the ability to have to bend over. And again, a lot of that has to do with the center of masses. And I like to call this the path of least resistance. The body will find a way to get there regardless of where the restrictions are. And we know this about any movement pattern. If we're not establishing true movement or mobility in certain joints, then you're going to be limited in those joints, which ultimately leads to a compensation elsewhere in the body. So we can look at, we're very good at identifying postural compensation, but we need to understand where that comes from. And again, like I said, we're going to see a lot of nuances with this toe touching pattern, and you'll be able to predict just about anything else in the ACM assessment just from this outside of the ankle mobility range. So those are just some of the things that I look at in a toe touching pattern from the coronal view, and I'll show you that in a second too, from this direction. So this is what I've, shoot, let me just see one thing. Yeah, and so when it comes to measuring, what we're really looking for in the toe touching pattern is, does that sacral angle? And so if you imagine someone standing, the femur lines straight up with the sacrum, as they bend forward, we're looking to see how much that sacrum or the pelvis tilts forward in an anterior position, and that sacral line should be greater than 80 degrees. You can see that. This is mine. This was years before I even was starting the ACM protocol. I would just test with my feet apart. I can still touch my toes with my feet together. But again, that's the reason. I guess I should step back and say the reason why we always test with our feet together is because we want a standard way to measure so that it's replicatable across whoever you're measuring, and the results are replicatable from one person to another, inter and intra reliability. But there was a time when I could never touch my toes. My fingers were literally at about my shin, my mid shins. I was over probably 10, 12 inches. I've mentioned this before. My sit and reach test was always a -11. I remember that number from high school and junior high. but it didn't come from stretching my hamstrings, as I stretched them a ton. Came from understanding the mechanics of the things I'm going to share with you right now. So acceptable would be a sacral angle of greater than 80 degrees, like these two. She's at the point, she's the model that I use in my pictures. She's got some lumbar flexion, which we'll talk about, but she does get a good hip hinge, as you saw in the picture above, with her center of gravity, and she has a really acceptable angle of her sacrum, as opposed to this gentleman. You can see how you can just look at someone's belt line and just assume that's their pelvis moving. Obviously, you have to take a little more insights to that, but you can see that his sacral angle is very minimal, and the majority of his toe touching comes from his lumbar flexion. So this would be less than 80 degrees, and that would be unacceptable. We'll look at that a little closer, but this is kind of how we look at the sagittal view, the coronal view of the toe touch from the side view, what we would jump out at first to look at. This is just an illustration of skeletal imaging. You can see the sacrum here. Obviously, that's almost a 90 degree or greater than 90 degree angle of the femur to the sacrum. But like I mentioned before, let me just show you this. If I take this line, we put it in this image, we can look at his center of gravity, where his feet would be centered, and then we look at his center of gravity. And again, these are animated images, so I don't ever use skeletal animated images to represent what we really want to say, because it's usually wrong. But you can see the center of mass of a human, which would be the skeleton, is way forward of his toes. This is going to just create tremendous stretch. This is an animated picture, so this is, I guarantee, we're not going to see someone with that much of a hip angle, that much of a forward center of gravity in this position, but the image shows you. So I want you to look at that center of mass, where that center of mass is relative to the person's toe touch, and it should literally fall right through their ankle joints. So anyway, this is a good example. I just wanted to share this image with you about the sacral angle that we're looking at without any clothes or skin on, but you can see the sacral angle relative to the femoral position. Then you have to take into account the lumbar flexion, the spinal compensation. But those are the keys I'm looking for in a toe touch pattern. I hope that makes sense. So moving on, I mentioned we're looking at the toe touch pattern from a bilateral standpoint, meaning that both feet are the same. The pelvis is moving. We're assuming it's a bilateral function, meaning even on both sides. So the coronal view is looking at from the person from the side, which is what we're doing here. This is the coronal view, looking at the side. We're not able to deduct anything asymmetrical in this position of this assessment. So from this coronal view, we're able to deduct the amount of hip flexion. We can interpret any hip internal rotation. We'll talk about that a little bit later. We're looking at spinal flexion. Again, how much is the spine flex? And then we can also look at the center of gravity distribution. Where does that fall? And those are really good indications from a bilateral standpoint of what the body's doing in that coronal plane. I have this other slide, so let's take this one out. I already have this slide later. We'll talk about it. We'll talk about a unilateral plane in a second. But what I wanted to share with you, if you haven't been on the software, let me share with you how we assess the toe touching pattern and how the assessment works on the software. So again, we're just having someone touch their toes, and you have the ability to touch their toes or not. You can choose yes or no. If this person can touch their toes, yes. You can touch your toes or not. A lot of the research I read, the pass-fail criteria was really the ability to touch your toes or not, pass or fail. Well, we have a couple other nuances here that I want to share with you. If someone can touch their toes, the window will pop up about how difficult that was, because some people can really force it and they can get their toes, but it's not a true hip hinge pattern, and they're not getting authentic movement at that hip joint. And so we can scale this from 0 to 10, 10 being the hardest or very hard. So this person can touch their toes at a 4, their back doesn't round. The computer knows that anything greater than 5 or greater, that's not a true hip hinge pattern. If someone's really struggling to touch their toes, they still get there, I'm not gonna count that as a true hip hinge pattern. It's not authentic. It doesn't happen naturally. They have to really force it. So we threw that little nuance in there to take a little subjectivity out of this, but the answer being yes or no, yes, they can. Difficulty wise, it's a 4. The computer knows that that's okay, and they don't round their back. It becomes a functional movement, and it always ends up toe touching as an F on the side over here and under the assessment line. Let's take a look at a couple other scenarios. The person can touch their toes, yes, but now they really forced it, they bounced, it was a 7 out of 10 for effort. That would be considered a dysfunctional, even though they can touch their toes. So again, we want to get a little deeper into understanding how hard it was for them to do that. The next example is someone can touch their toes. It's only about a 4 out of it. It's not that hard for them, but they rounded their back. And there's a little subjectivity there as to how much rounding is acceptable. We'll look at some of the examples I have to share that with you, but that would be considered a dysfunctional movement. They rounded their back, they're getting toe touching, but it's not that hard. But where's the movement coming from? Is it coming from a true hip hinge pattern, or are we seeing a lot of that coming from the lumbar spine? And then the other dysfunctional would be a no, obviously. And if they can't touch their toes, regardless of any of those other parameters, we don't even ask them how hard it was because they can't touch their toes. We just would measure how far from the 4 they are, because we want to give them some insights to how well they're getting. Measure their inches and distance in inches and move on. That would be considered dysfunctional. So hopefully you guys have played with the software. It's pretty straightforward. As you go through the assessment, it gives you the little results on the side so you can keep track of it, and you'll have a better understanding of what you're seeing as you go through this. Moving on. So here's what I would consider acceptable spinal flexion and hip hinge. There should be some rounding of the lumbar spine. The lumbar spine should elongate. It should let go. Those muscles should be held, but there should be some tension in them. There's nothing wrong with some muscle tension in muscles. That's what supports our body. As soon as we go, and I have some research I'll share with this, but as soon as we go beyond the muscle involvement, if the muscle is so weak or so elongated, it lets go and just allows the body to move, which is what we're talking about. We want that essentially. And there's no muscle tension, then you start relying on the inner properties like the ligament structures and the discs of the spine to support that forward flexion. The more stress that's put on that inner properties of the tissue, those inner tissues or ligaments and discs, the more pressure and stress is put on those, and those can ultimately be risk factors and lead to injuries of the spine, all kinds of issues that you'll see about. But these are what I would consider acceptable. Obviously, the picture of me is pretty good. It's relatively symmetrical all the way through my spine. There's some rounding, but it's all symmetrical. This lady, she's pretty flat, and we'll look at that in a second. I'd give her an acceptable hip hinge. I don't think she has any issues with hip flexion problem. We'll probably find some issues in her backward bend or her standing rotation, if there are any, because of how tight this lumbar spine is. That tightness is probably indicative of a dysfunction somewhere. My model, obviously, there's some rounding in her spine, but it's acceptable. It's symmetrical all the way through. This girl, she effortlessly touched her toes. I looked at her sacral angle. I looked at her hip hinge. It's a pretty good hip hinge. Pretty good. She has a little bit of sarcophysis, and she's somewhat flat, but it's not bad. This is probably the end range of where I would say that it's acceptable. But it just gives you some examples of different visions of what you'd see. All of these would be a 4 or less in effort. Okay, this is an example of excessive spinal flexion. Obviously, the one model I had, the kid, he got no hip hinge, and it's just all flexion. If you asked him how difficult this was, he said it wasn't very difficult at all to touch his toes. But where is he getting the hip hinge pattern from? You can see the lady here on the far left. It's all lumbar flexion. And this gentleman, he's got a lot of kyphosis, but he's also got lumbar flexion too. I have a lot of examples of that. But this would be what I would consider excessive lumbar flexion or spinal flexion. Spinal meaning the whole kinetic, or the whole segmental spine. This is what I would consider excessive thoracic kyphosis, or we call it ETK. There was actually a study that was it wasn't a study. It was a paper on this new syndrome, ETK, and it sounded so serious, but it just means excessive thoracic kyphosis. Now listen, when you have someone bend over, you're going to see flexion in the hip. You're looking for that, but you're going to see all kinds of different things. You can see both of these people have extremely flat lumbar spines. This guy's a little bit massive, so it's kind of hard to see if he's actually got a lumbar spinal flexion, but you can see it's pretty flat, comes to a peak, and drops right down. This woman has really flat lumbar back with a lot of kyphosis. The reason why I would do these pictures with my employees was because most of these people, when they sat, that's where their back collapsed. And so again, we should have a lot of movement at the pelvis, and lumbar spine should be symmetrical. You can tell if you were to put any of these people in a sitting position, these people would sit very differently than these people. And you can see where I get the path of least resistance is. To get down the thoracic back, now the thoracic back is. Excessive thoracic kyphosis, ETK. There's a couple reasons people have this. Some of it, there's some papers and research about it being a congenital problem. And sure, I would probably move into genetics slightly, letting that be an excuse. But regardless, we still can have a huge impact on a person's biomechanics and posture, even though I don't like using the word genetics, but genetics does play a role in this if it is a congenital kyphosis. Most people, it's a path of least resistance. There's something missing in this kinetic chain that isn't allowing them to move efficiently. So just keep that in mind. So those are some examples of the toe touches that I see and come across, and how I scale them and measure them. Now, I mentioned to you, we do the toe touch from the coronal plane, from the side view. This is going to give us a lot of understanding about just bilateral functioning. But we can also look at the toe touch from an asymmetrical standpoint, from the sagittal plane, looking at the person from behind or in front, and we're going to measure right to left differences, because this is where you'll really start seeing those nuances. And so here's some examples. The person with the circle around him, I'm looking at muscular muscular atrophy or size just in the lumbar erectors, the erector spinae. And you can see that this guy looks pretty symmetrical. There is a difference in his scapula. If that's his scapula, it's hard to say, but the muscles of the scapula, the teres major or lat. But you can see the difference on those two muscles groups or scapula. But you also look at this lumbar spine, and again, in person, you'd be able to see someone through their whole plane as you're looking at them. But I would probably say this guy's got a little bit of musculature girth on one side, on his left side versus his right. And just make a note of it, that you notice a difference right to left. That shows asymmetry. And in the ACM assessment, we're looking at some assessments like the toe touch and the backward bend are looking at bilateral movements, whereas a few of the other ones are really looking at asymmetries. But you'll probably find this come out in his standing rotation or sitting rotation pattern. This girl, you can see that she was pretty flexible. I think I scored her acceptable on her toe touch, but you can see an asymmetry. You see how one pelvis, well, whether this is the PSIS, posterior superior iliac spine, as somebody's bending forward, you're going to see the tip of their pelvis tilt up, their sacral angle and tilt. You may be higher on one side than the other. Whether that's the bone, whether that's the PSIS or the sacrum or the musculature of the glute, because you're going to see the musculature of the glute medius and glute larger on one side. If you see that, especially glute medius being a little bit more lateral, you're going to see excessive musculature girth on one side versus the other. It tells you a lot about someone's ability to stabilize and move from that hip socket. But this girl, I definitely saw a disparity there and found it in her standing rotation. It was really interesting. This girl was this is a picture I pulled off the internet. It was just a girl doing yoga, and I'll actually move this line away so it doesn't distort it. But you can see that she's a fit model. She looks pretty symmetrical. But when she bends forward, she's got a slant in her body. Now, when I was a kid, and most of these nursing programs in schools now not now, but in the past, used to do the scoliosis test, just bend forward, and then someone would look at your spine to see that it was straight. Now, we hear about functional scoliosis and congenital scoliosis. Congenital scoliosis is a deformity of the vertebral bodies, and it usually starts early in life and progresses until our growth plates and our growing spurts stop. And so they'll be concerned with that in someone that's young. And so even if someone has a congenital scoliosis, you're not going to see symmetry in their back. Just understand that it's still muscles, it's still bones, and we still have an impact on this. If it's a congenital scoliosis, there's a lot you can do to work with people. Are you going to correct it? Probably not. You're going to be able to influence some muscle imbalances that are there. Worked with some young kids that have avoided surgery, but they had to be very vigilant about doing their exercises to establish that symmetry. The majority of people out there that you're going to work with, I would guess, will probably have what we call a functional scoliosis, a difference from right side to left. And again, we have to take in the ankle considerations, hip joints. We have to take into all this consideration as to why that spine is offsetting or rotating. But again, I'm very good about looking at this sagittal plane view so I can get an understanding if there's an asymmetry that I need to really pay attention to in the rest of the assessment. And that leads me to the single leg toe touch. If you do see an asymmetry, you start noticing, gosh, look at the difference in the spinal musculature or the pelvic positioning, then just take it into a single leg stance. Now in the assessment, our 6 movement patterns are scored. The ankle mobility, toe touch, backward bend, standing rotation, single leg stance. The single leg toe touch and the single leg backward bend are just ancillary tests to confirm what you're seeing. So what happens is if someone bends forward, touching their toes, and you see an asymmetry, if it's a pretty big asymmetry or there's a noticeable difference, then I always take them to a single leg toe touch just to see if it's a hip flexion problem or something else. And so what you're doing with this is you're just putting your client's foot up on a 8-inch, 6-inch block just to get their knee in a little bit of flexion, because you're going to take out the hamstring involvement and glute involvement here, and just have them bend down. And just notice what they do right to left. You can even ask them subjectively how they feel or how they felt that, but you're going to notice that you may notice that one side moves better into forward flexion than the other side, and that would be an indication that it's a hip flexion, hip internal rotation problem, which we'll talk about in a second here. So I usually assess the single leg toe touch when I find a big asymmetry, and I want to kind of determine if that's a rotational hip socket problem, but we'll also be able to confirm that in the standing rotation, which we'll talk about some other time. So that's when I use a single leg toe touch. It doesn't, in the software, the single leg toe touch is just a validation test to make sure that you can kind of see where this is going in this person's assessment. It doesn't have, it's not implicated in the results of the assessment and the outcome of the assessment. Just an ancillary test for you to have confirmations with. So when we talked about toe touching, most of us think about just the pelvis tilting forward or the leg coming up in the flexion. But what happens is, and I want to stop sharing for a second so I can show you this here. If you can see my screen, I have my friend here, my skeleton. But the hip socket, from this coronal view, the hip socket isn't orientated at a perpendicular angle. The angle is actually down and forward. So the hip socket is pointing down and forward relative to where the person's standing. So that means that as someone goes into bending forward or their leg is coming up, what's actually happening is the hip socket is internally rotating on the ball. The ball is internally rotating in that pelvis, which is why we always say that, which is why I will always say that, let me go back to sharing this, which is why I'll say that toe touching is also synonymous with internal rotation. And again, it's why the standing rotation test tells us that if we find someone who's very limited in toe touching, we're going to see that limitations come out in their standing rotation, because that's including internal rotation. So again, they blend on each other. But this is just an example of the different ranges of motion. The hip socket that we're looking at, we're really concerned mostly with the hip flexion, which is either the pelvis coming forward, which the touch is doing for us, or the femur coming up into flexion. As that happens, as that occurs, the femur is actually, the socket is actually rotating internally on the femoral head. Again, going into the internal external rotation components, there's a lot of testing for this, but most of it is unloaded, and meaning they stand and twist their leg, they sit and twist their leg, or they laying their stomach, internal, external, or on their back, supine or prone. And all those parameters are still looking at about 45 degrees, 40 to 45 degrees of internal rotation versus external rotation. They're about the same range. So it's just another understanding that if we have limited internal rotation, if you find that somebody has limited internal rotation, then their toe touch pattern is going to be probably poor. If you want to break it out a little further, if they have poor toe touching pattern and you're not quite sure what you're finding on that standing single leg stance test, or sorry, the standing toe touch pattern, then have them lay down and see how much internal and external rotation they get. You may find a lot of restriction in that internal rotation, which is where a lot of people have problems. And I'll show you why that is in a second here. So that talks about some internal rotation. I just wanted to show you that there's a correlation between toe touching, hip flexion, pelvic flexion, and internal rotation. All right. So just keep in mind, it's not just looking at flexion. We're also understanding that the femur rotates inward as the pelvis tilts forward, internal rotation. So let's get into the musculature real quick. And again, we could spend all day on this, but what most people are concerned with is the posterior chain of musculature, and that would be the glute, the hamstrings, deep six, and we're going to look at those, break those down. The hamstring obviously is the big culprit here. Most of us associate the inability to touch our toes with tight hamstrings, and we feel the tight hamstrings, and you very well may have tight hamstrings. But we have to always, and I will emphasize this, and if you want to take one thing out of this presentation, is understand that just because a muscle is tight still doesn't tell us why. And then we have to take a step backward and start asking ourselves, why is that hamstring so tight? Was it from an injury? And there's some research about the football players that I mentioned, the Australian football players, that said that a toe touching pattern, the hamstring extensibility was not correlated to risk of injury. And they said the majority of the injuries that were post-injury assessments, the hamstring tightness that they were assessing was as a result of the hamstring pull. So someone can develop a lot of contracture in a muscle, especially in fascial and scar tissue, and have lost extensibility of a muscle muscle function because of an injury. So it could be because of that. But we also have to understand why. Why is the hamstring so tight? And I always go back to what I mentioned before. Where does that center of gravity fall in someone bending over? Where does the center of gravity fall in their static posture? When we look at someone standing from the side view, that sagittal or the coronal view, are we seeing their whole body shift forward? If so, something's got to keep them from falling over. The hamstrings are going to kick in. Also, when we talk about the posterior group, the glutes, the hamstrings, the calves, the gastroc, if you will, and then we'll look at the spinal musculature. This entire posterior group is responsible for us falling over or bending over. They're all eccentrically loaded in that position. In order to get out of that position, or what we would call hip extension, or standing up, or pulling the leg back, this is what this group of muscles does: the hamstrings, the glutes, the deep six, calves, the erectors. But one of these muscles, and I'll let you take a guess looking at just the picture of these, this being the most superficial on the right, these two muscle groups, the glute, the hamstrings. I'll let you guess which one's the dominant mover of this kinetic chain, posterior kinetic chain, meaning which one is the one that's doing primarily responsible for extension of the leg. It would be the glute. The glute is the biggest, largest muscle of the body. When the glute is not functioning correctly, then guess what takes over? The hamstrings. And so the hamstrings become a synergistic dominant muscle group. They're doing the work that the glute doesn't. Remember, when we bend over, the glute muscle is stretching as well as the hamstrings. The glute muscle, that's an eccentric load. You're lowering the body down. You're pulling the muscle or stretching the muscle under load, eccentric. The glute muscle should be firing at that point to slow our descent down. If it's going to take a vacation and not do the work, guess what's going to pick up? The erectors and the hamstrings. And the hamstrings get extremely tight. And when the leg goes back behind us, that hamstring group is pulling the leg back, or the glute is. Which one do you think should do the work? Obviously the glute. The hamstring becomes a synergistic dominant muscle. Let's take a look at this from this, again, the hamstring groups. You can see there are 3 hamstrings. They start all attached at the ischial tuberosity and behind the pelvis, and they come down and they split. One goes to the outer knee, the other part goes to the inner knee. So biceps femoris, long head of the biceps femoris, goes to the outer knee. It's the big fat muscle, and it is usually the dominant group muscle in that group. The other 2 muscles, semimembranosus, semitendinosus, attach in the same spot, but they come toward the medial side of the knee. And I won't get into too much detail, but they do pass the joint. All 3 muscles affect the tibial position, so they're flexors of the knee and extensors of the hip. But these muscle groups are responsible for become synergistically dominant and responsible for hip extension and can get extremely tight. Biceps femoris can be the dominant group in that one, and that will actually also start causing a person's foot to turn out. There's only one muscle in the entire body that turns the tibia out, and that's biceps femoris. And we can look at that some other time. But if you understand that the 3 muscles come down, they both attach to all 3 of them attach to the tibia. It's like horse reins. As the person sitting back here on the wagon holding the horse reins, if they pull the horse's rein one way, it's going to turn the head to the right or the left. Well, those muscles working together keep the tibia tracking straight. So if someone squats down and you see their feet turning out, there could be a lot of reasons, and it doesn't really even matter what the reason is. What's happening is biceps femoris is becoming stronger. So when you're training someone, it's critical that you have people's feet pointing straight so that they're not going after their biceps femoris as a dominant muscle. So anyway, the hamstrings are a big group in this. The gluteal muscles, I mentioned this before, but we have the big glute maximus, then we have glute medius underneath that, and then underneath that is the glute minimus. You can see it here. But those 3 muscles are ideally, the glute maximus is responsible for hip extension. There's some posterior fibers and inferior fibers of the glute medius and glute minimus that assist in hip extension, but the glute maximus is the prime mover. It's the biggest muscle of the body, and it's the most dense and one that should be doing the work. We rip those layers away, we get rid of all those gluteal muscles, and we start looking at the deep 6. These guys are external rotators. I call them the deep 6 external rotators. It's the piriformis, the obturator internus, the obturator externus, inferior and superior gemellis. These guys are and the quadratus femoris. These guys are the ones responsible for rotating the femurs out. So think about that. If toe touching is a hip flexion and internal rotation movement, and the external rotators are extremely tight, guess what you're going to feel? You're going to feel very tight in the glute, and it's not anything to do with how tight your glutes are. It's probably tightness of the deep 6, and this is where sciatica and the piriformis syndrome really come from. So what is the remedy? Well, let's stretch those glute muscles. Let's stretch those deep 6 muscles, but they're generally too tight, and for a reason, there's an imbalance somewhere else. We're going to look at that right now in a second. This is another example of where those muscles are orientated around the body. You can imagine going in hip flexion. Those muscles are going to be extremely tight and limiting the flexion as well as the internal rotation of the femur. The other big one, and I will say that more so than hamstrings, it's the adductor magnus. Now we have 5 adductor muscles: pectineus, adductor brevis, adductor longus, adductor magnus, and then gracilis. 5 muscles, they're all listed right here. You've got pectineus, brevis, magnus, and, well, I don't know where longus is listed here, and gracilis. Magnus, adductor magnus, oh, I didn't have it, close off. Adductor magnus is a huge muscle, magnus meaning huge. Its origin is anterior pelvis on the pubic ramus, and posterior along the ischial tuberosity. You can see from this direction that orientation of where that muscle is. I thought I had a better picture of it, but I don't. You can see that the posterior fibers of the anterior of the adductor magnus. You have the anterior fibers of its origin in the front of the pubis. Posterior fibers are all the way back on the ischial tuberosity. Here's a posterior view. This being adductor magnus right here has a posterior attachment to the pelvis as well as the femur. So adductors are bringing the legs together. Your adductor group, those 5 muscles, are also responsible for hip flexion because they all originate anteriorly on the pelvis. So it makes sense. Hip flexion, adduction, and some internal rotation. That would be great because that's what we're trying to get. We're trying to get internal rotation, hip flexion when we do a toe touch pattern. The problem is, or the interesting part is, that adductor magnus acts like a hamstring muscle in a way that is posterior to the pelvis on the ischial tuberosity, and the posterior fiber is attached to the femur. So they have a huge influence. It has a huge influence on restricting forward flexion, and it becomes a synergistic dominant muscle in hip extension when the glute is minimized. And most people have very weak glutes, and if you can guess why, you get 5 bonus points, because we sit all the time. Our butts are planted on a chair for most of our day. We're never activating the glute. But if the glute becomes weak and inefficient, the adductor magnus is going to kick in, and that's why people feel really tight adductors. You might see some valgus stress, all these indications as to tightness of the adductor muscles. So adductor magnus specifically. Tight adductor muscles would incur with internal rotation of the femur and flexion. So it's not a bad thing if we're looking at good toe touching, but obviously we need this balance. But the adductor magnus can take over, and it becomes a huge dominant stabilizer and mover of that lower leg, along with the hamstring muscles. So it's not just hamstrings. Adductor magnus is probably having a bigger influence in the inability to touch the toes because it's so strong and big. What I did here was I broke down every range of motion: hip extension, hip flexion, abduction, adduction, internal and external rotation, and then obviously knee flexion, extension, internal and external rotation of the tibias. But this is our lower extremity musculature, minus the muscles of the foot and ankle. We'll get into some other day. I went through that with us on the ankle mobility program. But this just gives you kind of a checklist to understand some of this stuff. And I want you to look at hip extension. The blues are prime movers. The same color, or the bold colors, are the prime movers. Everything else is synergistic. So the muscles of synergy in the hip flexion, we mentioned all the adductor muscles, sartorius, rectus femoris, gracilis. So if we're talking about muscles that are the inability to touch our toes, then we have to start looking at what muscles are the opposing muscle groups: glute medius or glute maximus, medius minimus, piriformis, the deep 6. I just included deep 6 there as piriformis. Biceps femoris, the hamstring groups. We can say, okay, great, let's stretch these muscle groups because they're really tight. Or we can also say, listen, let's strengthen the opposing groups or the antagonist, and that's really what we want to do. We don't want to just stretch the tight groups. We want to also activate those antagonistic muscles, the hip flexors, the adductors. But we also have to be careful where we're strengthening adductors. The more extension we go into, the more we're probably going to be activating the glute max, adductor magnus in an extension position. In hip flexion, we're going to be truly getting adductors. So just pay attention to that. That's why I have in here hip extension. When you're to get hip extension, when the hip is in extension, the adductor magnus posterior group becomes very active. When we're hips in flexion, to get hip flexion, the adductor magnus is kind of taken out, the anterior portion is used. So just kind of look at the chart. This is a great way to start learning muscle groups and patterns, and understanding how corrective exercise really plays a role in activation as well as stretching a tight group. So we can say that the hip flexors, the hip extensors tend to be very tight. The hip flexors become very inhibited. And the same goes with femoral internal rotation, femoral external rotation. The external rotators will probably be very tight, glute maximus and such and forth down, whereas the internal rotators are weak. So we can go after a lot of adductor work here. But I'll tell you this, and I'll share this with you when I was doing some work with some people on toe touching. We'll look at that when they do the corrective exercise. So that's just a chart for you. Here's another way of breaking it down. I put this together for you so you can just look at groups of muscles and understand what they're responsible for in femoral rotations and movements, so we can start kind of figuring this out. Basically, extension, flexion, abduction, adduction, internal rotation. It's just a good reference chart for you guys. Looking at ligament structures of the hip socket, I told you this can be an entire full day course, but I just want to share with you that the hip socket is comprised of all this musculature that controls it, but we have a strong ligament structure of the hip socket that supports us in a standing position. And I always use the analogy of a finger, those Chinese finger cuffs, or the Chinese finger locks. When you put your fingers in those bands and you pull out, it tightens. Well, you can understand if we're looking at the front of the hip on this anterior view, when you lift the knee up or the hip up in the flexion, that ligament structure unwinds and it becomes loose. That's why in hip flexion we have a lot of movement. When we go down into hip extension, imagine this leg dropping down, that ligament structure tightens and it locks on itself so that we can stand in an erect position as long as we have good balance, posture, with very minimal muscle involvement, just twitches. We're not actually activating a lot of muscles to stand. We don't want to waste effort. These are the inner structures that don't have an energy demand to them. They're just locked. And so the hip socket is kind of like the finger cup. The posterior view is the same analogy. When the leg is flexed, imagine that femur going forward away from you. That ligament structure unwinds as the leg goes down into extension. That ligament structure tightens. And this can be this again. You got someone with tight ligament structures. This is where they probably would need some joint mobility. Either get better parents next time because ligaments are relatively genetic how tight they are. But someone with injuries, we can get contractures in these hip sockets, these ligament structures, and there are some good mobility drills for the hip socket itself, self-mobility drills that can really have an impact. There's some other stuff out there about hip impingement and things. It's very similar to the shoulder, and it usually results from muscle imbalances that we saw in all the pictures I showed you. But there's some stuff you can do with joint mobilization. And again, if you're trained to do joint mobilization, then go after it if you feel that that's a restriction. But there's also some good joint mobility restriction, mobilization stuff that you can learn. So I just want to share that with you, that the ligament structure has an impact in this as well. But again, going into hip flexion, those ligaments should unwind and have very little influence on the tightness of the hip socket. Real quick, we have to also take into consideration the posterior back muscles, which the first layer is obviously the biggest one is the lat that attaches to that lumbar sacral fascia. That lumbar sacral fascia, that white stuff down here in the bottom, is also part of the attachment of the obliques and rectus abdominis. Well, obliques, internal, external, and transverse obliques, not necessarily rectus abdominis, but all continuous. But that lumbar sacral fascia can get extremely tight, especially when someone has tight lats, has an overarched back. And then we start looking at the posterior back muscles, all the erectors, the longus, the spinalis, and the iliocostalis muscles. They just get very tight. And these are muscles that I look for in asymmetries. I look for tightness. I look for those muscles to let go a little bit when they're bending forward. They should. So just keep that in mind. We're looking at everything in this kinetic chain. Here is an example of excessive tight lumbar musculature and excessive thoracic kyphosis. You can see that every one of these persons is almost arched the other way into spinal extension, or kyphosis and lordosis. Excessive lordosis with excessive kyphosis. These are pretty big disconnects. The lumbar spine is trying to do one thing while the thoracic spine is doing another. And you're going to see a lot of musculature imbalances here, a lot of issues with this stuff, especially when this is why I said the toe touch pattern tells us a lot more than just hamstring extensibility. So start getting away from understanding hamstring extensibility and looking at these components. So with a few minutes left, I want to just go over the corrective exercises that I put together for the toe touching patterns. And if you were with me a few months ago, I actually switched, I added or changed one of them because usually when I get people that have a really limited toe touching pattern, then you might come across clients that have back pain. And although we're not treating pain, we want to take that as a pre-consideration. So I changed one of the exercises. I'll show you what I changed in here and why, but I always start with cats and dogs. It's a bilateral flexion extension motion of the pelvis. And this is really where you can cue people and help them. This is a great test to first see how much movement of the pelvis they get versus thoracic or lumbar movement. And you'll see people that have really poor kinesthetic sense or really poor connection to their body. They don't get any pelvic movement and they just round from their back. All the people that I see with kyphosis, like those last people I just showed you, tend to have very poor understanding of how to establish lumbar pelvic rhythm. And so this exercise is all about lumbar pelvic rhythm. We're not stretching anything. We're establishing a bilateral position of the femur as long as everything is straight. So from this exercise, I will make some modifications. If I know that someone's got some really tight internal rotators or really tight external rotators, or really tight adductors more so, I will have them spread their knees apart into a V position, or I may even have them go into a split position with one leg or the other and have them work through that range of motion to influence more of that capsular stretching. But the cat and dog is one of my favorite go-tos for lumbar pelvic rhythm, and it's pretty much safe with just about anyone. But you'll get a good assessment during this exercise as to how much lumbar pelvic rhythm a person gets. And regardless of how well it is, keep coaching them on establishing that lumbar pelvic rhythm. And it should be a good indication. If they don't have that, how can you expect them to do anything else in your training if they're not even established the right rhythm of the lumbar pelvic rhythm? Then I move into foot circle point flexes. And this is really to help prime the hip. Again, it's that knee flexion, hip flexion position. So we're looking at really just helping establish some movement of the hip socket to make sure they can get full flexion of that socket. Plus we're priming the separation of the hip flexion, hip extension, which is important in the gait pattern, as well as priming the hip flexor muscles, the dorsiflexors. We talked about this in ankle mobility patterns. We really have a lot of weakness in the anterior compartment of the foot. So this is a great exercise. It's the primer of getting the hips to start functioning well in an unloaded position. We go into the active frogs, one of my favorites, just to establish internal and external rotation bilaterally unloaded so the hip socket can start understanding and stuff. If someone has extremely tight adductors, I might actually have them contract their glutes here as they're going into external rotation, use the glutes to pull them out of that adductor engagement, and then come back into internal rotation. If I know someone has some big restrictions in internal rotation, I may actually have them spread their feet apart width of the mat and have them go internal rotation and external rotation here too. You can make some modifications to this just to influence the internal external rotation. You can split it and have them go internal external also. Then I move into going after the antagonists, and this is one of my favorite exercises to really give someone it will give you a good assessment as to where their problem is, and it'll really highlight that client as to how weak they really are. It's the straight leg raise, or the active straight leg raise with presses. So what I have people do is I press into the table, or I'm sorry, press into the floor, press into a block to engage your abdominals and support their core while they're in a straight position, not going into flexion. I always have them keep their head down and pull their shoulders back, pack their shoulders and head straight. So the spine is learning that straight position. We're getting them out of any of that kyphosis or excessive lumbar flexion. We're using abdominals in a straight position, so they're learning a new pattern. But what we're really doing here is separating the hip flexion and extension component and encouraging the activation of the hip flexor, primary hip flexor. You're going to get some synergist stuff here, like the TFL, glute medius, glute minimus. They're all hip flexors if you look at my chart, as well as the adductors. But we're going after primary hip flexion. But you'll see people here struggling. You may actually even be surprised when someone has an inability to touch their toes. When you get them in an unloaded position, they can get their legs straight up. That tells us it's purely a weakness, not a hamstring extensibility problem. You may also find people that are extremely tight in this position, so I modify it by putting one foot on the wall. But this is a really effective way of activating those hip flexors at a high level to get them going. Unloaded, it's a pretty safe position. That's why I use it to go after the antagonist, which is hip flexors. to start priming those guys to take over for the tight hamstring muscles, right? That's the antagonistic group. And then I'll go after some glute function. Again, like I said before, I had a friend who was not able to touch his toes. I had him do 10 hip thrusts with a bar, 135-pound bar off the bench. He did it 10 times. He was crying because how weak his glutes were. I had him stand up immediately, touch his toes. He went all the way down. That one problem, he could not believe that just doing that one exercise is not a stretching exercise at all. We're going after glute activation. If you think about what glute activation means, we're getting the glute to fire. If we bend over forward, the glute is pulling to keep us from falling. If the glute's active, it's gonna take over for the hamstring. If the glute doesn't do anything and just lets go, the hamstring has to do all the work in that forward flexion, right? So when I got his glutes to fire, his butt muscles were holding and his hamstrings could let go and not be the prime cause of this. So glute activation is a big one. I'm a big fan of this one. If you got someone with some really tough issues in the extensibility of the hamstring, get the glutes to start firing and start working on those hamstrings. This is the one exercise I took out because people, some clients have a difficulty in the toe touch, and it creates, you're going to see in the research that the correlation between tight hamstrings, the inability to touch your toes, and the flexion of the spine and the components of that. So I didn't want to put that risk out there, but I will tell you that this toe touching sequence, which I learned from Greg Cook, it's really effective. And if you think about what we talked about in the very beginning, about the center of gravity, the shift in that center of gravity, this is what this exercise does. You start with your toes on a board, 1.5-inch board, and bend forward. As you do, your body has to shift and reestablish balance, the center of gravity, and you'll see it in about 5 to 10 reps. That person's hip hinge will start establishing itself. That's all we're looking for in this pattern. Bend their knees if they have to. Squeeze that pillow really tight. We're going after the adductors. Remember, adductors are hip flexors, internal rotators. So it's encouraging the pelvic flexion while the glutes can shut off. We're going after the antagonist. The glutes can shut, or the hamstrings can shut off. And we're establishing that center of gravity weight shift, which is really critical. And you'll see that hip hinge. As soon as you see the person hip hinge come out, you'll see it happen right in front of you. You won't believe it. The body will fall forward. This pattern brings it back. It's the coolest thing. But I wouldn't put someone through this if they have some back complications, only because it's just adding that risk that you don't want to take unless you feel comfortable that they can do it. This exercise, the kneeling ankle squeeze, I use this to just reestablish glute activation and abdominal activation. It's that lower cross syndrome. I use this a lot in establishing just the overall mechanics of the body, static posture, or it's really more of a static position. But it's going after glute activation and abdominal activation, the two weakest links in that lower cross syndrome, versus lumbar extension and tight hip flexors. So again, I use this to just lock in that pattern of what we're trying to achieve. And I don't have this in my corrective exercises, but I work on the hip hinge, and it's something that I would put at the end of all of this, is to start establishing what that hip hinge should look like. But I've had people that if they don't have the capacity in those other exercises, you're not going to get it out of this hip hinge exercise. But if you can get it through those patterns, then you can start really establishing what that hip hinge should do with a stick or on their shoulders or on their back and butt, and just get them to start practicing the hip hinge. The majority of those exercises should improve this. Again, someone with excessive kyphosis, rounding of their back and all, we have to go after some other activation muscles of the spine to establish that. But it's a great exercise. That's what I really wanted to cover today. Like I said, this could be an 8-hour course on itself, just the toe touch pattern, because of all the things that are going on in it. But I'll tell you that this toe touching pattern, if you look at those aspects of it that I mentioned, you'll be able to predict almost what you're going to find in all the other patterns, especially the asymmetry patterns, everything but the ankle mobility. That's why you have to check the ankle mobility. But someone who has excessive thoracic kyphosis, I'm going to have a little red light on saying, okay, I want to watch their backward bend and I want to watch their sitting rotation, because if that thoracic kyphosis is strong, then it's going to be very limited in those other two patterns. If they're just going in there because it's weakness and it's their weak link in that chain, and that's how they get there, you may not even find a problem in that. That just tells us that there's a weakness. But if you find that there's tightness and it's leading to that thoracic kyphosis, it also gives you a good insight to where to go. Our corrective exercises focus on those. Those are the reasonings before the very specific corrective exercises we put together in all these patterns. But this is the toe touch. Hopefully that was helpful. A lot of information. I'll tell you that the more you study, the more you go and start testing people, start understanding what you're seeing, and using that chart I gave you of the musculature. It's just the lower extremity musculature, pelvis and knee. It will give you some insights to what's actually going on in these patterns. And so I wanted to say the toe touch pattern is a huge assessment to use, and really encourage you guys to start using it as often as possible so you can get comfortable with seeing a lot of different things. And you're going to start finding that these corrective exercises have an influence in just about all of those. And any questions, feel free to reach out. And I want to say thanks for joining us. All right, take care, guys.